We looked at pre-exposure and post-exposure regimens. We evaluated drug-drug interactions. Now, given a patient case where an adult patient with HIV is experiencing intolerable adverse effects, recommend appropriate management.
So when it comes to adverse effects, of course, the newest nukes actually are generally well tolerated, whereas the older nukes had severe toxicity. So mostly because of mitochondrial toxicity. So zidovudine, which is one of the oldest ones from the 80s, and we still use it because it's available in IV formulation, and also we have significant data in pregnancy. So it has all of those terrible side effects that all the old nukes have. Now, with abacavir, of course, you can have hypersensitivity reactions, so it's important to check for HLA-B5701 polymorphism. TDF is nephrotoxic and bone mineral loss, so osteotoxicity. And TAF is an improved version of TDF, so it's well tolerated. So it can still cause some nephrotoxicity and bone mineral loss, but it's not to the extent of TDF. And emtricitabine can also cause hyperpigmentation. So when it comes to, so you can see they have looked at the bone mineral density over 48 weeks in different studies, and they can see like how much bone mineral density loss has occurred once the drugs have been studied. So you can see that most bone mineral density loss occurs in the studies that actually has TDF. So tenofovir disoproxil fumarate, you can see all these yellow or orange, I guess, all these orange lines. There's significantly more bone mineral loss, whereas when we change that TDF to TAF, TAF is significantly less bone mineral loss compared to the other formulations that have TDF. Now, with the integrated strand transfer inhibitors, which are first-line recommended regimens, are pretty well tolerated in general, and so they are both effective and well tolerated, and they actually do pretty well against resistance. So that's why they are recommended first-line. One thing about raltegravir, it can actually increase creatine phosphate kinase or CPK. With elvitegravir, you can actually see proteinuria. And when it comes to boosted protease inhibitors, darunavir is well tolerated. Lopinavir is a relatively older protease inhibitor, so you will see more adverse effects, especially some changes on EKG. Etazanavir can actually cause jaundice, so in a lot of areas they actually call it bananavir. So bananavir because it's common to see jaundice in patients. So because of that, because of toxicity, actually, these two agents are not used as much anymore. Darunavir is better tolerated. So should we need protease inhibitor, typically darunavir is the drug of choice. And the reason we would need protease inhibitor is because they actually do significantly better against resistant HIV even compared to second generation integrase inhibitors. So they are, typically when patients experience treatment failure because of resistance, protease inhibitors are drugs that we go to. But because of these side effects, and also drug interactions, we don't use them initially in someone who's treatment naive. So with the non-nukes, the two that you will commonly see are efavirenz and rilpivirine. Rilpivirine is actually well tolerated. The reason we don't use it first line is because for rilpivirine to be effective, the CD4 count needs to be greater than 200 and a viral load less than 100,000 at baseline to start it. So that's, considering how many other options we have, that's a lot of things to look at. So rilpivirine is not first line anymore. But efavirenz actually has CNS toxicity. So one thing that a lot of patients will complain about is vivid dreams. So they could be so much that that the patient will actually stop taking it. Now, for a lot of patients, these are supposed to go away after 2 to 4 weeks of treatment. But if they persist after 4 weeks, then it's a good idea to switch them to something else, because as time goes on, this can lead to non-adherence. Another thing that's important, this CNS toxicity can also cause suicidal ideation, and that's actually the primary reason efavirenz is not first line anymore, because it actually increased the odds of suicide attempt and completion. As I mentioned earlier, cobicistat can actually block MAT1 or MAT1, and MAT1 can actually secrete creatinine. So by blocking this, it artificially artificially increases the levels of creatinine in the blood. So it doesn't really change GFR, but it can artificially increase serum creatinine. So here are some numbers. So cobicistat, because it increases serum creatinine, if you're using Cockcroft-Gault equation to calculate creatinine clearance, you will automatically get the number that's 15, can be up to 15 milliliters per minute lower. So now rilpivirine and dolutegravir also have some, they also can increase serum creatinine, so keep that in mind. So when it comes to different regimens, it's important to consider renal function. So this is creatinine clearance cutoff. So for elvitegravir, cobicistat, emtricitabine, whether it's with with TDF. So this is Stribilt. So with Stribilt, it's actually, so if the patient creatinine clearance is less than 70, it's not recommended to initiate it. So in order to start Stribilt, which has both cobicistat and TDF, which can affect creatinine clearance, it has to be greater than 70. Now, if it's somebody's creatinine clearance is 72, and you started and it goes to 65, you can continue. But if it goes below 50, then it's recommended to discontinue, and that's in the package insert. Now, with darunavir, cobicistat, and TDF, the cutoff is also 70, but they don't really say anything about once it goes less than 70. So once it goes less than 70, you have to discontinue it, because it doesn't have a statement about going less than 50. But with Stribilt, definitely you can continue until it's less than 50. Once it's less than 50, you discontinue. But with darunavir, cobicistat, once it's less than 70, you discontinue. So you can see the cutoff for some of the other agents. So for most of them, whether it's TDF or dolutegravir, it's 50. If you use the TAF formulation, anything with TAF, whether there is cobicistat or not, with TAF the cutoff is 30. So definitely that improved it. And most recently we have the combination that doesn't have the backbone, so there is no TDF or TAF. So we have a dolutegravir with rilpivirine, and renal function doesn't matter. So for these combination, you can use it at any creatinine clearance. So should someone need a reason to change their ART, whether it's because of intolerable adverse effects or because the renal function got worse, or whatever the reason, there are some basic principles that should be considered when switching, in patients who are virologically suppressed on the current regimen. So one thing, so although they may be virologically suppressed on the current regimen, it's important to review their past history to make sure they didn't have resistance to regimens in the past. So if they did have resistance in the past, you want to avoid those agents. If they have had resistance in the past, it's important to consult an expert. Generally speaking, switching within the same class is not an issue. So, if someone didn't tolerate efavirenz and you were to switch them to rilpivirine, it will be okay. However, if switching between classes is a little more tricky, so you really have to know what you're doing. So, for example, if someone is on a protease inhibitor and you're about to switch them to a non-nuc, so if someone is on darunavir and you're about to switch them to efavirenz, you have to be careful and make sure that it will still be susceptible to efavirenz because you're switching between class. But generally speaking, it is possible to switch between classes if you don't have reason to believe that it will be resistant.